politics, we're now in the year where the election is going to happen in the fall, and that always sort of slows things down and makes things more difficult, and in this kind of scenario makes things more polarizing. So I think particularly from the House, you're going to see a lot of oversight of the National Institutes of Health and of the Centers for Disease Control and Prevention, and the Administration for Preparedness and Response, and sort of how all the different agencies have acted. And there's been a lot of finger pointing over the past few years, by the Democrats when Trump was in office, and then now that Biden's in office by the Republicans. So unfortunately, I don't think it's going to be a time when there's going to be a lot of positive legislating. I think you're going to see a lot more oversight and hearings, but not a lot of bipartisan work on legislation. There's a few things that might happen. There's some programs that need to be reauthorized as sort of part of good government. Some of those related to opioids and substance use support. I think that those probably can get reauthorized, but there's a big pending reauthorization of the Pandemic and All Hazards Preparedness Act, which was passed after 9/11 and the bioterror, anthrax attacks. And every 5 years, Congress is supposed to go back and reauthorize those and update them. And that's been sort of stalled out, despite the fact that there was some bipartisan work in the Senate to do it. It hasn't moved forward. It's been caught up, and it doesn't really look great, but that's going to get reauthorized. So, the Hill is a place where there's a lot of talking, a little bit less action. On the administration side, there's lots of activity. And we mentioned Dr. Ford's work on the administration's social determinants of health plan. So I won't talk a lot about that in great detail, but I'll just say I have a particular interest in that because one of my roles at Levitt Partners is running a coalition called the National Alliance to Impact the Social Determinants of Health. And NASDO was founded about 6 years ago, and we've been hoping that there would be a big national strategy and a real focus on it. So it's just incredibly encouraging to see that come out. And it captures a lot of what the administration is already doing and also looking forward at things that they want to do. So I won't go into detail because we have the author of the plan here. She can do it better than I can. But I will say, it's just an exciting time in the administration, and it's really a time to get a lot done because there is a legislation there's a law called the Congressional Review Act, which allows Congress to go back and undo administration's regulations. And it tends to only come into play with a change of party in a certain set of scenarios, but it means that when you're in the administration, I was in the Obama administration in the last 2.5 years. And so we were thinking about that in the event of a change of control, what can we get done before that deadline of when Congress can sort of look back and more easily undo something the administration's done. So the administration's kind of in that golden window right now where it's the time to get stuff done before that deadline, which is sort of summer-ish. It's a little bit hard to calculate because it has to do with how many days Congress is in session. But it's a really busy time. So I think we've seen a big thing come out in November, and I think we're going to see a lot of continued activity. So I think I'll leave it there and pass it to the next person, Jean.
Terrific. Why don't we go to Dr. Ford since we've been talking about her plan?
Well, let me be crystal clear. It's not my plan. And there were a lot of major contributors to the playbook, including John Auerbach, who was a huge champion of that work. And so I think that Sarah did a great job of talking about what will most likely happen. So I'll go to the more aspirational piece of it, of what I would love to see. As we talk about social determinants of health, and just for clarification, those are the non-medical things that contribute to wellness. For example, homelessness, food insecurity, educational achievement. And so, we learned a lot about that during the pandemic, because a lot of what was really killing people was not necessarily their ability to receive medical care, but the other things, in their environment. And so what I would love to see, and we're starting to see more of it, is more financial support for the social determinants of health. We are not going to survive the healthcare crisis focusing just on clinicians. It takes too long to train a clinician. It's too hard to ensure that they will actually become primary care physicians. And so we need to figure out some other ways to address this. And I think that investing in the social determinants is probably certainly a more cost-efficient way of addressing this issue. We've seen a lot coming out from CMS in terms of what they're willing to support based on the social determinants, much more flexibilities around what they're covering, home and community-based care, things along that line, much more emphasis on that, which I think is very encouraging. I hope that we continue to see more focus on the public health workforce, particularly community health workers, because I think that they're going to be a key component in moving forward in ways of providing services that don't necessarily engage doctors and nurses. For example, the whole social determinants piece, the community health worker designation is so broad that, with the appropriate levels of training, they can be very, kind of jack of all trades, depending on what it is that we need to focus on. And I think that's going to be very important moving forward for the healthcare community. I've seen, even in terms of the social determinants of health, an expansion of what is considered a social determinant of health. We're talking more about climate change and how that impacts underserved communities, language access, health literacy, things that we weren't necessarily thinking about when we first started talking about social determinants of health. Now the definition has gotten more broad, and so that means that different sets of people will be interested in that work. And so I think that those are some big things. We will not ever, I hope, in the next decade, stop focusing on behavioral health. But I think that the link between behavioral health and physical health and the social determinants of health has become much more clear. The connection between your mental state and your ability to function, in the world just as a human citizen, and what that means for your health outcomes. And so I think that the more we link things, the more clearer understanding we have of why people live the way we live and what we can do to change that. Thanks.
Thanks, Dr. Ford. Why don't we go next to John? John, what are your thoughts about what we can expect to see in the year ahead in policy?
Sure. Well, the truth is, I agree with everything that Sarah and Sandy said, but maybe I'll add an additional few thoughts. I think in terms of public health, this year will represent a fork in the road, where we're going to see either a recognition that public health has been underfunded and that contributed in a great significant way to some of the challenges of COVID, and therefore we need to put more resources and more priorities on public health. Or the other fork in the road could be public health is overstepped its area of responsibility and should be scaled back. We've seen some proposals already to significantly reduce the size of CDC and have it do less than it's currently doing. So I think this is going to be part of the presidential debate, I suspect, is what needs to be done at the federal level. But I think it's going to play itself out at the state, local, tribal, and territorial levels as well. One reason for that is that we're going to see a continuation of the ending of the funding that was available from COVID, which even though we don't feel like we're in the worst of COVID now, a lot of the funding that was passed by Congress was for multiple years. And so, for example, there was a $3 billion grant program that the CDC put out, $3 billion, about the largest program CDC has ever done, that went to the states and about 50 local communities, and gave them enough money to hire some kind of an unprecedented number of workers to work on any issues that those states and locals thought were the key issues, including working on infrastructure, the kind of skeleton that's needed in order to make sure that you've got the body of work, public health, sufficiently supported. When that money starts to run out, then there's going to really be a significant problem. And either funds will be passed at the state, local, tribal, territorial, or federal level that will maintain some or all of those funds, or we're going to see widespread layoffs and a reduction in the kind of services that we've come to expect. Now, I don't want this to be all doom and gloom. I also feel like there's real opportunity there are many people across the country who have learned through COVID that the problems that were encountered reflected the fact that we needed more resources and that we need to pay a lot of attention to the sector. And we're seeing in local communities and states initiatives to pull together people to talk about that and to do cross-sector planning. Indiana, for example, a Republican state, has developed a really excellent proposal, bipartisan proposal that will strengthen the public health system and put new money into it. Maryland, Washington State, other states are also going through that kind of a process or have gone through it already. And in some local communities, the same thing's happening. So if there continues to be some momentum to talk about those issues and to plan for the future, I think this could be a good opportunity. The one final thing I would say about this is, COVID was not the last emergency we're going to face. If we learned anything over the last several years, it's that the number of significant emergencies is increasing, both related to novel viruses, climate change, and other factors. So what we don't know is whether in the coming year, we're just going to find we're once again in the midst of a significant health crisis where the ability of the public health system to respond is going to be tested, and that may result in greater attention to the system, or it may result in greater criticism. So again, fork in the road is what I would say the coming year represents.
Thanks, John. That's so interesting. And I have some follow-up questions and thoughts for you about some of that in terms of that fork in the road and what we might see. But I want to give Harry a chance to respond as well. And in particular, Harry, you've done a lot of work. I didn't read this when I was reading your bio, but you've done a lot of work at the local level and the state level here in Georgia to try to kind of move the needle on some of the underlying, access issues. And so I'm really interested in your thoughts as we think about kind of the year ahead and policy, especially if you have any kind of, observations based on what you've seen happening at the state level and the local level.
Yeah, it's always challenging when you don't have to update talking points about Medicaid expansion 12 years later. But that's the nature of life in Georgia. So really appreciate all of the insights shared by others, and especially the kind of shared recognition that the Obama administration, the Biden administration, new chapter, similar, has really prioritized upstream social determinants and racial equity in ways that have really moved administrative actions in powerful ways. Obviously, we need more than administrative actions, but even the ability in the Medicaid program, for example, starting January 1st, to fund community-based violence prevention programming in hospitals and potentially school settings, Medicaid as a connector to housing. I mean, all of those are powerful opportunities. But I think John's right. I mean, there is kind of this existential fork in the road of is public health something bad that gets us in trouble and is kind of contrary to what a state like Georgia, which touts itself as, quote, #1 for business, aspires to, or is it a critical partner to everything that we collectively want to achieve? I'd like to just highlight a couple things that are maybe a little different than what others mentioned, including state level things. One is along the theme of social determinants of health, expanding the child tax credit, something that we have a proof of concept from during the pandemic, is in the current discussions with Senate Finance and Ways and Means. So that by itself would be a powerful push in the right direction towards bringing more financial security to low-income families and bringing more children out of poverty. So I think that's something that I'll be keeping an eye on. At the state level, women's reproductive health is an area where I think public health advocates will need to continue to play both offense and defense, depending where you live. Same is true for protecting LGBTQ rights, particularly for trans and other non-gender conforming children. And then last, gun violence is an area where there may be some state level opportunities given the lack of movement in Washington. I know in Georgia there are bills around safe storage and more narrowly focused bills trying to reduce access to guns by youth and children. As I mentioned, in Georgia, we're still working to expand Medicaid, despite the fact that we have, I think, the third highest uninsurance rate in the country, and health outcomes and inequities to match. Continues to be a heavy lift given the perspectives of our governor and the Republican-controlled legislature. And then in Georgia and other states, again, relevant to social determinants, there continues to be important bills trying to move forward access to housing, affordable, high-quality, sustainable housing for low-income populations. Housing, I think, is a national issue, but it's being more debated in terms of solutions at the state level. And there are others. And then the last thing I just want to highlight is the Supreme Court. I don't need to convince anyone that there have been and will continue to be powerful decisions at the Supreme Court that either expand opportunities for health or create increasing barriers. And a few cases to keep an eye on. One is the case affecting mifepristone, which is the abortion pill. The other is a bill that challenges the Chevron doctrine, which is so the FDA authority has been in place, and their decision about mifepristone was in 2000. The Chevron doctrine goes back 40 years, which basically says that when there's an ambiguous statute, we defer to the relevant agency's interpretation. And I trained in health law from Gene, so if I got that wrong, please correct me. And the third one to highlight is EMTALA, which is a law which requires emergency departments to stabilize folks. And the Biden administration made it very clear after the Dobbs decision that that includes pregnant women whose lives are threatened by complications to pregnancy. And needless to say, we've seen horrendous cases across the country where women have been challenged to get the treatment they need. That case will also be coming before the Supreme Court. So,
Harry, those are some really great points, and thank you for talking about public health laws. It's near and dear to my heart. For those who don't know me well, I am a public health lawyer by training, in addition to being a DRPH. You mentioned so many interesting things, and I think one thing that struck me as you were all sharing your thoughts is the very wide range of issues that are potentially on the table. John said we're at this sort of fork in the road, and Harry, I think that's what you described. And Sarah, you described a Congress that probably isn't going to get a lot of actual policy making done this year. And Sandy, you talked about the promise of sort of some of the things that the administration has been able to complete and work on, and all the important opportunities we have at the state and local level. So I'm just, as I hear you all saying that, and I hear all these different things, I'm sort of struck by just that vast range. And so I'm wondering, I want to ask you the next question. Maybe we'll just go back to Harry to start with, and then, go to Dr. Ford, and then John, then Sarah. But if you could pick out one of those things, if you could, ask the public health, Dr. Public Health community here, the public health policy community, if we could all just sort of focus on a handful of things, what would those be to you? And I'm really curious, if we could get something done in the next year, 18 months as a public health community, what would your wish be? Where would you start? So Harry, maybe we'll go back to you, since you mentioned the Supreme Court and some of the really impending things on the table.
Well, the challenge with public health is there's a universe of critical issues that collectively I would argue, need to engage in. But if I had to choose two, I would start out by going back to John's fork in the road. I think in the absence of more substantial investment in public health infrastructure and workforce, and I'm not just talking about a one-time pandemic-related $3 billion investment. I'm talking about $4.5 billion every year, and right? That sustained high level, which we're basically set up for failure before the pandemic. We were understaffed, underfunded, and we couldn't respond in the way we need to. I mean, in Atlanta, as Dr. Ford knows, when it came time to start giving vaccinations, we had to stop doing testing and some of the contact tracing, because there just wasn't the staff to do both. So I think we've got to move away from this kind of crisis to complacency nature of funding, and so that would be for me number one. And I think while federal action is essential, I think there are a few bright spots on the horizon. John mentioned Indiana, I'll put in parentheses, of all places, which has made a sustainable investment at the state level, and they're not alone. Also true in Washington State and Ohio and Kentucky. So there are some kind of positive outliers, if you will, and they're not the ones you might predict. So I think at every level, it's incumbent on us to make the case for investments in sustainable infrastructure and workforce. And the second thing I would put on my list, which I think is the other kind of existential threat to public health and candidly everything else, is climate change. And I think that we need both sustained and targeted resources to address not only the increasing number of emergencies that we're facing, but to invest in climate resilience, particularly targeted to those communities that are already experiencing social and economic disadvantage, health inequities, and are the most vulnerable to the impacts of climate change. So I'll stop there.
Thank you so much, Harry. So many serious topics and things to consider. Dr. Ford, do you want to comment? What would your wish be?
Well, I definitely agree with the workforce development for sure. And I see that somebody stole my idea in the comment section, because my recommendation would be data modernization. We don't have data that tells us anything in a timely fashion. Everything is 2 years behind if you're lucky. And so we haven't done a good job of pleading our own case, because we can't back it up with anything. During the pandemic, for the first 3 months, depending on where you live, we weren't even collecting racial and ethnic data because we didn't have the capacity. We don't have the capacity for data integration and data interoperability, which would help us, much better address the social determinants of health. And so until we can really understand how to collect data and push it back out in a timely fashion in a way that is easily interpreted, it's going to be a constant challenge for us to justify the work that we do, because I can't read something in 2024 that was put out in 2022, because the world is completely different from that. And so, when people ask me right now, do you have data on diabetes? Well, yeah, but it's nowhere near current. And so I feel like once we shore up our data collection, our data integration, I think that the way we do work will be so different, because we'll have real-time information.
I love it. Okay, so we've got now the sustained infrastructure investment in workforce and data modernization. John, what about you? And then we'll go to Sarah.
I think I would propose that my wish list would be public health going deeper and going broader. And what I mean by deeper is that there's more efforts for the public health sector to be strongly connected to people at the community level, particularly those populations that are at disproportionate risk of preventable illness, injury, and death. what we've set up is a system over the years, which makes it real challenging to get federal money or state money down to the community grassroots level, often to the groups that are really making a difference and have the trust of the communities they serve. And so there are, I think, a lot of efforts now to overcome that, to look at the reasons, those obstacles. Sometimes it's a procurement rule that just makes it hard to get money to a smaller organization. Sometimes it's how challenging it is for a small organization to write a proposal. Those are things that can be worked on, and they're creative workarounds. So I think we will be well protected as a sector if we have strong community support. And that requires not just showing up when there's a crisis, but being there day in, day out and channeling resources to the community and having the community involved in decision making. The second thing, that's deep. The breadth is really going back to Sandy's point around social determinants of health, and that is we have to solidify the connections between the public health sector and these other sectors. It can't just be, we'll work with them only when their work is entirely based upon our priorities. It's really got to be the sectors coming together to support each other in ways that are mutually beneficial to the organizations and to the public. So an example of that is $500 billion has been passed for transportation reform in the country. $500 billion, $500 billion. Those dollars are going out now throughout communities throughout the country. Public health really needs to be at the table with the transportation officials, offering support and advice and bringing in community members and supporting the transportation system, not just standing on the sidelines saying, well, we're only going to show up if our priorities are also the priorities of the transportation system. So solidifying those connections to the community and solidifying the connections across sectors in very practical, day-to-day ways, I think, are protective for our sector in terms of being able to be insulated from some of the bad things that could happen, but also I think will build support for restoring the resources that are needed.
Thank you so much, John. Those are great points. So deeper and then breadth in the community and then the work across sectors. Yeah, thank you. What about you, Sarah? What's your wish if we worked on one thing?
It's hard to go left when you have three wise people in front of you, because I agree with all the things that they have said. And I had been thinking of an answer that has a lot of similarities to what John was saying in particular. The lack of confidence in public health is the biggest threat to accomplishing all the things that we want. It's hard to ask for more money for the infrastructure, the people infrastructure, the data infrastructure, if people sort of don't believe in public health. And I really think that the way to get there is what John's talking about, that public health is a partner at the table with a bunch of other sectors that haven't been as politicized and have been better resourced. And if we have some local wins on the ground where public health is no longer viewed as those people that made me stop doing fill in the blank thing that you love that you couldn't do during the pandemic, public health, even though they were standing up trying to protect people, sort of took the blame for all of the negative things. And I think some wins on the ground in all kinds of different political climates is really what's needed, because just standing up and saying, please trust me, please, invest in me is not going to work without sort of some proof there. So I think the kinds of things that John is talking about is what it takes to get there, and to have actually, local champions for what public health can and should do. Because we've really seen, as you all probably well know, a hollowing out of the support at the state and local level, just literally the dollars that go into public health. There's some bright spots where there is sustained investment, but in a lot of places, it's almost entirely focused on the federal dollars that come in, which, come with a lot of restrictions and what they can be spent on and how, and time limits. And it means that priorities shift over time as funding levels go up and down. And it doesn't actually even take that much to have some investment and stability for public health. And I think that that's how we're going to get there, with those wins on the ground, that public health is viewed as a useful partner to all those other sectors.
That's a great point, Sarah. It's interesting and important. And when we think about kind of support for public health, I want to go back to John and to Sandy and ask you, kind of given your recent experience inside you know, the current administration, and knowing what we sort of know about, you know, political instability and, you know, where we're at in this country, just sort of overall in terms of division and people around their thinking about what's important to them, what they prioritize, and how they might vote. I'm just wondering if you see things that our audience, knowing that this is an audience of people who are mostly either doctor of public health students or graduates who are out working in the field, if you think there is anything our audience should in particular sort of really keep their eyes open for in terms of being able to perceive the shifts, or maybe, John, as you said, at which direction we're going in the fork in the road, that they should keep their eyes open about over the next year, any kind of signals or things they should look for, good or maybe not so good for public health. Anything come to mind?
Well, you know, one thing I would raise, and this may be an area of interest for folks who are completing their doctorates now, is that we really have treated the workers in the public health sector pretty poorly. You know, if you have a doctorate in public health, you know, probably the place that you're likely to be paid the least is government. And that's, you know, just wrong, because you know, I think those of us who worked in government, you know, I think everyone on this panel will say that people work incredibly long hours in government for, you know, not much pay relative to what they can do in the private sector, and under enormous stress, and you know, layer on top of that the attacks that people in government have had to endure. Particularly, I highlight the public health workers that have been attacked. So I would just say, I think it's really, I think we all, regardless of where we land professionally, need to create opportunities for people to enter the public health field, make enough money to support their families, and, you know, buy a house and send their kids to college, and not feel like they've got to leave the profession. At the state and local level, 46% of the employees have left public health in the last 6 years. 46%. That's like, you know, that's half of the sector. Some people just retired early, but some people said, I need to go work somewhere else because these jobs are too hard and, you know, they don't pay enough. So I think we really need to focus a lot on supporting the sector in all ways we can, the employees of the sector in all ways we can.
Thank you, John, so much for saying that. I know that really probably resonates with a lot of our members here, and also with probably some of the panelists. It's a hard thing. I think one thing I've often thought myself too is normalizing that career transitions in and out of government, between government and the private sector, are something that, you know, isn't necessarily a bad thing either in public health, that we need people to go back and forth. Is something else that might help improve kind of that situation for everyone as well. So I'll go to Sandy next. Any thoughts, Sandy?
You know, it's hard to follow that, because that really is the gospel. I mean, and I think there's a lot of factors that contribute to that. You know, I think I've been saying this for almost 20 years now. I think public health has not done a good job of hyping themselves. You know, I think that people don't even really understand what all we do. I will give you an example. In my DeKalb County days, they were threatening to cut our budget one year at the county level. And I just went before them and read off the scores from the restaurant, you know, at the restaurant that they were going to have their next meeting at, that had an abysmal score. And I said, I don't think you understand what we do here. You know, and they put our money back after that. You know, and I think we need to do a better job of tooting our own horns about the value of the work that we do. Because what I said to them is, you know, I've lived here, I probably called the police maybe 3 times ever, but public health touches me every day, because I go in a grocery store, I go in a restaurant, you know, my child eats in the school, you know, these are things that we are impacting every day. And I think we have, as a body, have not done a good job of promoting ourselves. And so, you know, that factored in with the whole, you know, level of mistrust that amplified around the pandemic, you know, has put us in not a positive light, and for reasons I'm completely unclear on, because, you know, I remember seeing the folks banging the pots and pans on the windows, because at the time I was down in Fulton for Grady Hospital every afternoon, Grady and Emory, but nobody was banging pots for us, and that really bothered me because we were there too.
Yeah, thank you. Thank you. Yeah, definitely there's a lot we could do, and the association, that's part of our mission, right, is to help support the field. So appreciate everything you've both shared. Harry, what about you? Oh, you want to jump in? Feel free.
I just wanted to add one comment to that
Yeah.
and it's there isn't an organization or agency today that's not talking about diversity, equity, inclusion, access, belonging. And I think for public health agencies and organizations, the imperative is to do that work, both looking internally and looking externally, right? How are we operating internally, and what are our relationships and partnerships and collaborations like externally? I would argue that part of that internal work, part of the equity component of that internal work, means ensuring that people are getting paid equitably and getting treated equitably and fairly in their jobs. Obviously, this is a policy conversation, and there are considerable budgetary policy challenges around that. But when we talk about sustainable public health funding and workforce, part of that sustainability has to be ensuring that people get a competitive wage that make them want to remain in the public sector. And community-based organizations doing this work are struggling with many of the same issues.
I love it. You've touched on so many important things, and equity, of course, and not being the least of it. We only have a few minutes left, and so I see some comments. People are wearing their NADrPH hoodies as we speak, and also there are some questions in the chat. We don't have a lot of time left. I knew this time was going to go really fast with this group, just because there's so much to talk about and so many things in the horizon. We've covered a lot of interesting ground, from the opportunities ahead to sort of the very disparate things that are going on across the country, from the federal level to the state and local level. And so what I wanted to do was just give the panelists maybe an opportunity to share kind of a few last words, each one of you, about what you think they could do as members of the public health, profession, leaders. In some cases, I see there are CEOs on this call of other health-related organizations, and I see some students. I see people are in senior positions in nonprofit organizations and consulting companies, and a few government folks. Is there something that the panelists want to say to these folks about, what the audience here today could do, especially this year, to try to help position public health policies, or really just kind of support the field in general? Is there something you see that they could do, or something you want them to be aware of? So we'll just kind of go around, and sorry to spring this question on the panel, but I'm trying to figure out how to pull together all the things we've talked about in this call into some action maybe that our audience here could take away for what they do next. So Sarah, you didn't have a chance to speak, so sorry to put you on the spot, but would you like to go first?
No problem. I've actually been thinking about this a little bit. I was actually made my way to DC as a fellow funded by the Association of Schools and Programs of Public Health. They funded a fellowship for me, and that's what got me to the Hill. And then I just loved doing the policy work so much. I've stayed, and here we are 15 or whatever years later, and I'm still doing that work. So they had invited me to serve on a panel that I've been doing for the past couple of years, looking at the future of public health and how we need to change the educational curriculum and the positioning of schools of public health. I've actually had the benefit of thinking about this a little bit. And I think one thing that sort of overlays all of the conversations we've been having is that public health's role has really changed. There's always been different specialties of, are you an epidemiologist or environmental health, but also the, not just the specialty areas, but the skill sets you need to work in public health and to be so multi-sector and partnering with others and picking up and playing these roles in policy and other areas. So I would say, you know, for every individual here, you know, seeing if you have those skill sets to do those things, then also, I think most importantly, training and helping get the next generation of people in public health ready to do all of those things is critically important. So I think that that's a mission we can all take on. And I think about it with, we have a lot of students that are in public health school that come to our firm and spend a semester with us learning about policy work. And always just trying to think and embed in them as I'm, you know, mentoring and training them, the world of possibilities they have working in public health, but also this array of skills that they'll need, that you can't just study your epi and think you're only going to do that. You need to understand how it connects to policymakers and how to get funding for the work you want to do and how to talk about it in ways that are going to matter to those that are going to see your research. So I think we can all take that charge ourselves to do that with particularly the up and coming leaders in public health. I think it's really important to the positioning of the field moving forward.
Thank you, Sarah. Thank you so much. John, any thoughts?
I think I would, you know, say, you know, given how important this year is, I would say, since you, by definition, have expertise in public health, I would participate in whatever public forums you can in the coming months and elevate what public health is, how important it is, what it actually means. As Sandy was saying, a lot of people don't know. So I'd say, you know, whether that forum is local, whether it's a public or private meeting, or whether it's at the state level, or even if there's a presidential debate and you get to ask a question, I would say, you know, not taking for granted that people know and appreciate public health, but, you know, making the point that it matters and talking about it in really concrete ways. I think the more that we can just integrate that into all of our lives, it will help the well-being of the sector. But you in particular, given your expertise as you know, doctoral students, I think really are uniquely positioned to do that well.
Great, thank you. Thanks, John. Dr. Ford or Harry, either one of you want to go next?
Since you gave the X signal, you know, when I think about public health, you know, it's such a broad set of knowledge skills. And I think of all the different places that, you know, people with a public health background can be so helpful. And so, you know, to students, I would say, you know, don't just focus on, you know, running a health department or running, you know, a state agency, because when I think about public health, you know, I think of the questions that people have asked me over my career, urban design, you know, of course, policy, you know, healthcare leadership in general. So really, you know, because the training is so broad and the exposure is so broad, I mean, think about everything that you do in public health on a daily, you know, the places that our expertise could be useful are probably way greater than, you know, what most folks are thinking about. So, you know, just be open to how your skill set could be useful in maybe some non-traditional areas.
So just to build on what everyone else has said, and going back to John's fork in the road, I would argue that being a bystander and sitting on the sidelines in regard to public health policy is never a great idea. But now in particular, it's a really bad idea. And it's really incumbent on all of us to find a way to engage. And it may be forums, it may be reaching out to your state or federal legislators to say, hey, you know, I'm a public health expert. There are a lot of critical issues. I'd love to be a resource to you. And here are some things I'm particularly concerned about. The other thing I would like to highlight is John's point about the need for us to engage more deeply with communities, because ultimately we are that both resource for, but we need to be responsive to the communities, particularly those that need us the most. And the last thing I'll say is, if after hearing everything I said and everyone else said, it's kind of, well, that sounds great, but I don't even know where to start. There are health and healthcare advocacy organizations in every state. And not only are they there and would welcome your input and expertise, but they also generally follow state level health and public health related legislation. So you can actually follow their legislation trackers. So lots of ways to engage. From where I'm sitting, it doesn't matter where you choose, but engage somewhere. I think the more we all engage, the more we can help ensure that we get the outcomes that we're looking for.
Thank you all so much. This has been just such an amazing panel. This is so much fun. We appreciate you donating your time to the organization and giving folks an opportunity to hear your perspective. This is the first in our series of panels for 2024, so we hope that those of you in the audience will join us again. We have upcoming webinars, including run by the association, including one on DRPHers in the C-suite in February and careers in public health policy in March. And later this summer, we will host another webinar on happenings in public health policy as we get closer to the election. So we again appreciate you so much, John, Harry, Sandy, and Sarah, for taking the time to spend with us today. And for those of you in the audience, if you did not get your questions answered, we'll try to do some follow-up with the panelists here today for you. So again, thank you all so much. And it was a pleasure having you. Have a wonderful afternoon and a safe weekend, everybody.
Thanks, everybody.
Thanks so
Thank
much.
Thank you, Jean.
you.
Thank you.